Good afternoon, everyone. Welcome to today's national webinar presented by Policy Research Associates, AOT in Practice, Building, Measuring, and Sustaining Programs that Work. I am Alon Hope, and I'm the Vice President for Research and Evaluation here at Policy Research Associates. I'll be walking you through some of the webinar housekeeping before handing things over to our esteemed and wonderful panel today. Policy Research Associates, or PRA, is a small women-owned business. For over 35 years, PRA has helped national, state, and local leaders solve complicated behavioral health challenges through technical assistance, training, research, and evaluation. We at PRA believe in working together with communities to co-design practical, evidence-based solutions that provide measurable and impactful behavioral health transformation. In this webinar, Dr. Meryl Rotter, co-director and medical director for the Office of Prevention and Health Initiatives in New York's Office of Mental Health, will moderate a panel of experts, including Dr. Marvin Schwartz, professor from the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine, Dr. Richard Van Dorn, senior research associate here at Policy Research Associates, Dr. Cindy Gibson, director, Crisis and Justice Involved Services at Alta Point Health, Sergeant Nathaniel McCarty and Mr. Nat Pham, AOT program partners from Mobile and Baldwin counties in Alabama. The panelists will share what the evidence base tells us and what it demands of AOT programs, how two long-running programs have used outcome data to drive program decisions, concrete measurable strategies for improving AOT implementation, and accountability, and practitioner research dialogue on what evidence-informed actually looks like in practice. This is the third webinar in a three-part webinar series on AOT program legislation, implementation, and evaluation. You can find the first and second AOT webinars on our YouTube channels. And the link we'll provide in the chat. The points and views expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of our funders. If you have questions for any of the panelists regarding the technology, please use the Q&A pod found at the bottom of your screen. Throughout the presentation today, we'll pause and give time for Q&A after each topic. And so please attempt to keep your questions relevant to that topic at the time. But if your question gets lost or something else comes up for you, you can put it in the Q&A pod and we'll circle back to it at the end of the presentation. If you've updated Zoom recently, you may need to click the More button at the bottom and find the Q&A icon there. A couple of other reminders. The webinar is being recorded, so everyone who is registered will receive a link to the recording, and it will also be on PRA's YouTube channel following the event. There's also live captioning for today's event, and to view the live captioning, please click Live Transcript CC down at the bottom, and then show subtitles. And now I'll turn it over to Dr. Van Dorn and Dr. Rotter, and I'll be back at the end of the panel with some brief closing remarks.
Thank you, Elon. Oops. There we go. These are the three sessions, I think, right? You referenced. So here we go. This is our outline for today. We're going to look at really what the New York experience, as well as particularly experience from Mobile, Alabama. We're looking at what's generalizable and what's more specific, and hopefully get your perspectives as well. Looking at how to build programs, measure programs, etc. I was, as Elon mentioned, I'm based, as you can see, with the New York State Office of Mental Health. I will try to refrain from focusing on the NICs over the next hour and a half. It's hard to do, but I will try my best. I will say, that I've worked with PRA and learning collaboratives like this with AOT and mental health courts, among others. And what I hope to do is, as the moderator here, because we have a lot of very real expertise on this panel, is try to maintain a focus around AOT specifically, right? The AOT conversation, because it's about taking care of people, right, can bleed into conversations about good treatment, good services, et cetera, all of which are important. And we'll touch on some of that. But what we hope to kind of circle back to and get your get help to focus on is, how do we think about AOT from the perspective of differentiating it from the services that are associated with it? What's special about AOT and that context in the delivery of services? Where is value? What's the value added of having somebody in an AOT program in addition to services that might be available? What's the cost of that? Not just financial cost, but cost of liberty to the individual, their sense of autonomy, et cetera. And I'm delighted to have Nat here to help us think through some of those experiences as well as part of the program. So we'll be talking about all of that as we go forward. As Elon said, we want to make this conversational. So please be active with your questions. We'll try to get to them in real time and go back and forth as we move through a lot of material over the next hour and a half or so. Richard.
Yeah, thanks, Meryl. I think we're extremely lucky to have representation from New York here, both Meryl and Marvin. It's very important because that kind of set the evidentiary stage, and no state has implemented AOT like New York has. And so it's really important, I think, that we have a New York context and understand what that meant for AOT. But also, what does AOT look like outside of New York and outside of the New York context? And so that's where we bring in Dr. Gibson and Sergeant McCarty and Nat, and really trying to get an understanding of, as Meryl said, what AOT, what that legal clinical intervention looked like, and how we can kind of move forward from there. So that's the background, and we wanted to just identify signposts, building AOT programs, measuring them and sustaining them. And those are kind of our signposts. And as Meryl said, we were hoping to have lots of conversations. So ask lots of questions, please. New York matters, states and sites outside of New York matter. And I think reading them together is important. So that's kind of how we organized this.
And Richard, if I can be just to kind of make a sort of a concrete difference, then I want to turn it to Marv for some take-home points from his experience. Right? On the ground in New York, there, and maybe this is somewhat oversimplifying, but there are two basic sort of flavors here, and one of which is an AOT program that's separate from clinical services. It's a legal overlay potentially, but in New York, for example, there's an AOT. There's the court. There are AOT teams that are not providing services but helping the court monitor, and then the services are mandated, but they're not directly tied to the AOT. They're tied to the order itself, but not delivered by the AOT team. And then you have places like Mobile and many other places where there's a specific team tied to AOT cases. And it's one of the variations here. And we'll come back to New York and my experience in New York in a moment. But maybe I just want to kind of bring Marvin in here, who did some of the major evaluations, and to suggest some overall, to start with, any take-home points, Marvin, about your take on the New York AOT program.
Sure. I think that was a good summary of the unique elements of the AOT program in New York. One of the things that was most striking to me and unique about New York was the oversight provided by the state. So each county or region has a team, an AOT team, that's observing what's going on in terms of the treatment plan and treatment adherence, and they're independent of the providers. And when we were doing the evaluation of it, one of the things that the then commissioner, Mike Hogan, said, which I thought was an astute insight, was he said, what the AOT does via this oversight team is provides a level of oversight and accountability that really doesn't exist anywhere else in the mental health system. That it's sort of like having an Uber case manager. Like there's this layer of observation and accountability over the system, independent of the system, that really keeps people on track. Now, not every place does it, and it's not essential to success. But one of the things I like to focus on is, where does that function happen if there isn't an AOT team? Who observes or what's happening and tries to keep everyone accountable? The other thing that's, I think, a question that I'd ask you all to think about is, how does a program, an AOT program, actually get going and then be sustained? I've seen in where I live in North Carolina, because of a lot of system changes, it's largely fallen to disuse. So as you're thinking about your programs, think about how it gains traction and how it sustains the traction it has, because I think that's essential to these programs.
Thanks, Marv. And we're going to circle back as Richard laid out the outline for us to measuring programs. And so we'll come back to kind of looking at asking Marvin to speak more about what he measured and what they found in the sort of the evaluation part of the program. I want to call out two things and then maybe ask kind of Cindy as we kind of move forward a bit. But mention two things about New York State from my experience before we move off of New York State for the moment. One of which is the significant variability across the state in how it's implemented. There's, just for those of you who don't know, there's the downstate, there's New York City, and then there's what we call rest of state. There's everything else, essentially. And they're like two different places in many ways. And from that perspective, for example, there's many more AOT orders in New York City than there is elsewhere in the rest of the state. There, obviously much of New York State is rural from a geographic perspective. Then you have the concentrated people all in New York City. So there's significant variability. And one other piece of variability I want to share and is that, actually two other pieces I want to make. One other piece is the judicial variability. Richard was asking about, when you're talking to Cindy, about the specific judge, right? Even within specific courthouses and jurisdictions in New York State, there are different judges who hear the cases every week. So there isn't in every place an AOT judge. There are just different judges who handle a mental hygiene court, and whoever happens to be sitting that week will hear the cases that week. And there's a different person from the week before. So there's variability there as well. And then one last point I want to make about New York State, and again, it was something that I think that Commissioner Hogan said as well, was one of the ways they felt that AOT worked from an accountability perspective was provider accountability. That clients, because of that, due to their non-adherence in the past, before AOT, clients that providers would have said, well, they're not showing up, we're finished, right? They weren't able to let the person go. Now, it wasn't so there was a way in which there was provider accountability in terms of following up for people that they wouldn't have otherwise followed up. And that may be an overlap. I was wondering perhaps, to outside of New York State and how AOT may work. So maybe with that in mind, throw it to Cindy here a little bit. And as we move to think about outside of New York for the moment, what are your thoughts about? And Richard, do you want to set up Mobile a little bit, or have Cindy respond a little bit to the accountability question, provider versus client?
Yeah, no, I think it's a great transition and segue,
Okay.
because what you and Marvin just talked about in New York, and kind of that buffer, that AOT monitoring team, falls to Cindy's clinical team here. I mean, it's intertwined here, right? That is the AOT team's job, is to both monitor and report back to the court and provide clinical services. And so that's what I find so interesting about this. And so this is a slide. I hope you all can see this. We'll provide a little bit more in-depth infrastructure, but this is kind of the program in Mobile County, and it's very similar to Cindy's program in Baldwin County, which is just across the bay, except one very important factor. So I'll hand that over to Cindy.
Yes, so the factor is the judge. We had well, there's a couple of different factors between the two counties. One is more spread out. It's the largest county by land mass in the state, and it is a more affluent county. And the judge, he was my cousin for the majority of AOT. Well, he's still my cousin, but he's not the judge. But in Baldwin County, in Mobile, it is a more urban city. We have more crime in Mobile. We have more poverty and homelessness in Mobile. Baldwin County doesn't have homeless people because they don't have homeless shelters. Homeless people in Baldwin County get picked up and put in Mobile County, and they become residents of Mobile. So a lot of differences between the two, but the judge made it a lot easier to do in Baldwin County because he was very amenable to doing step ups and taking people from the community straight to AOT without that index hospitalization, and that made a big difference for us. And the judge in Mobile County was just a very strict sort of, he would have loved to have done status hearings on a very regular basis if he had the time. But in Alabama, probate judges are responsible for elections, guardianship, civil commitments, adoptions, condemnations, all kind of land proceedings. So he just didn't have the time, or he would have been much more involved. And so our first thing that we always say to participants after they're coming out of the hospital is we're just as court ordered to this as you are as treatment providers. And that oversight, like the judge would call us out on things. And so there was that accountability, but that accountability came from a program level more so than anything, I think. And then we had check-ins with the clerk, where the judge, he wanted to start doing check-ins, and so he was present for the first week and never again afterwards. But he did get information from his judicial clerk, and those were just our staff saying, hey, here are the folks that we have who are struggling and maybe wobbling towards revocation, and they would occasionally add some information, but not much.
Since we're describing the programs, I think now, Richard, just kind of, I think you're going to continue to contrast them a little bit here. So I just want to unpack one of the words you just said, just to start anyway. Revocation. What do you mean by revocation? And then maybe I'll ask Marv to step in. What that looks like in New York State. Okay. What do you mean by revocation, Cindy?
So a revocation for us is a revocation of the outpatient status of that order back to inpatient. And so, and that's a very interesting thing for Mobile County because the judge and I had a disagreement on what constituted a revocation. So for him, material noncompliance is the person, their car broke down on the way of that first appointment and they didn't make it. Well, they're non-compliant with that appointment. And so theoretically, there's material non-compliance and they should be revoked back to the hospital. Are they unstable and need that hospitalization? No. If they smoked a joint, they have violated that court order and theoretically should be revoked back to the hospital. And so my philosophy was always, we had to toe a fine line because I'm not going to send somebody back to the hospital unless it's clinically indicated to do so. And so we did have some disagreement around that. And there was pressure there a lot.
if I may ask, Cindy, just from a legal perspective, then I turn to Marv, so I just so I follow. So when somebody gets revocation, right, they're brought back to the hospital, but at that point, there's no requirement then for a physician or somebody to certify the person meets hospitalization criteria. I mean, they get the revocation can be the transportation back to the hospital, but it sounds like that person is back inside, period, irrespective of what a clinician might think at the front door.
Theoretically.
Theoretically.
Yes, most of the time that did not happen in practice. There had to be a clinical need for them to go back for me to file a revocation. And sometimes that ended up with some rubbing points between myself and the judge. But I don't believe in taking somebody's liberties if you don't need to. So,
yeah. Mark, want to talk about revocation in New York, or with that removal, as we call it?
Yeah, I think it's called a removal order in New York. And so in most states, and there may be an exception, what the removal order or the revocation, or in our state, it's called a pickup order, does is put the person in front of a clinician. So, and in some places they're taken elsewhere, but probably modally is taken to an emergency room or a crisis center. That gives the clinician the opportunity to evaluate the person for involuntary commitment. It doesn't give them, by and large, the authority to commit them. It's just that it de facto creates a custody order that puts the patient in front of the clinician who has the authority to do an involuntary commitment examination. But the other thing I just want to go back to emphasize, and Meryl, you made a good point about it. In the work we've done, we think the mechanism of action, by and large, of AOT or outpatient commitment is the effect that the judge issues the order, but the message goes to the providers, to the patient, and to the families. And there's this concatenating message that people care that you adhere to the treatment plan, and we're focused on it, and we're going to pay attention to it. And more than anything, we think that that's what makes it work. Actually, removal orders and pickup orders are relatively rare. And in many cases, we saw AOT working without any pickup orders, and we thought it had to do with everybody being on message about treatment adherence.
Thank you, Marv. I'm going to ask the sergeant in a moment about the law enforcement part as experience of revocation. But hang on one second, because I do want to pick up on something that Marv just said about the message being important, the message to the client, to the family, etc. And since we have an individual who got a message, Nat, I'm wondering, what was the message when you were told, I guess, or how when you got on AOT? How did you hear the message, or how did you experience that message?
The message of the involuntary commitment?
Yeah. Exactly.
Yeah. Like from the judge, or specifically, or just in general?
Yeah, however you want to define it. I want to hear
well, Dr. Gibson had mentioned liberty, and we had mentioned that earlier too. And that was one thing that, like I said earlier, when we were convening earlier, and like when it came down to it, I had relapsed a few times, and my experience with the probate court was that, I mean, the officers, they were kind. It's just like I was just around, peers that were just in the same experience, and because of the relapse, and then and it finally got to the last point where it was just like, hey, I think the judge had I think so, like us talking about it right now, and that's like a lot more that came back to it, like the probate court attorney, she worked with me diligently, and but I think I'm just thinking, I don't know for sure, but I think the judge had the power, like what I was listening is to put me back into involuntary commitment. And that basically kind of scared me, in a way, because like I had seen in inpatient the severity of the other patients that were with me and how long they had to be there. So my main point was like I was still able to have um rationalizations and like, hey, look, like you need to basically accept that I need to get my treatment in order to be back out, basically.
Right. Thanks, Nat, for that. And turning to Sergeant, thank you for your patience. Wondering from your perspective, there and your role in revocation, how does the law enforcement system, feel about being put in that position of sort of clinical enforcer, if you will?
Well, we have to realize that, hey, we're still dealing with a patient. This is someone that's in need of services and medical help. So we're not there to try and, so to speak, discourage the relationship, because at the end of the day, we still have to be the ones to enforce that order, right? But we also want to let that individual know that who we're dealing with. We want to let them know that, hey, this is encouragement for you to get better. This is encouragement for you to stay in recovery. And we want to make sure that we can be able to keep that relationship. So in the event that crisis does happen again, that we are able to encourage them and look at us as someone that they trust.
Interesting. And you feel you're able to communicate that when you're doing the actual pickup? Is that how?
Yes, sir.
Thank you.
Yes, sir. And from my standpoint, we're the city, so the county handles most of the pickups. But for us, if we get a call in our jurisdiction, then hey, we have to be the first ones to make that connection. And what we want to do is just simply build rapport and let them know that, hey, I'm not going to make you do anything that's going to harm you, but we want to make sure that you're getting the best care that you possibly need at this very moment. So it's almost like, let's listen, meet in the middle. Let's make sure that we're doing the things that we need to do together. We're working together, to make sure that you're getting what you need.
Terrific. One other thing I want to kind of pull out, Richard, from this slide here and get a couple of perspectives on. Interesting, this obviously this is the mobile county slide, right? And that the requirement for AOT doesn't include a dangerousness requirement. Some of you may know that AOT in New York was called Kendra's Law because it basically was precipitated by the murder of a woman who was pushed in front of a subway, a woman named Kendra Webdale. And so the law and so dangerousness was both the precipitant of the outpatient commitment law in New York State, and continues to be a part of the criteria for getting on. You get to non-adherence, but dangerousness that either led to hospitalization or just that overt dangerousness is a part of the requirement. But I take it it's not true in Mobile. So the criteria, Cindy, in Mobile are?
If the criteria is that there's the presence of a serious mental illness, we have a 2-year look back that resulted from legislation. About a quarter of the way through the Mobile AOT program, there was a change in state legislation that allowed a 2-year look back in terms of compliance, treatment adherence, and that there's deterioration. And so if there is a dangerousness component in Alabama, then that's the requirement for inpatient. So.
Great, thank you. And this is going to be a nice segue to the building the programs, Richard. But as we change the slide, I just want to note that there were a couple of questions. One of which is, and we'll circle back to, one of which was a comment about treatment court and the number of people who are behind bars who may be appropriate for a treatment court that are not getting there. And it's an interesting conversation because obviously treatment court is a criminal justice version of an outpatient mandate for treatment. And so we can maybe perhaps later, we have time, contrast civil versus criminal mandates for treatment and how those, others may be similar or different. And then there was a question as well about returning to AOT, and certainly I can speak for New York, and Cindy maybe you can speak for certainly if you're still eligible for AOT, you're certainly if you're back in the hospital and you're still eligible, you're certainly eligible to go back. It's not a one and done. It's really a matter of whether this is something that the clinicians and then the court agrees is going to help you in the community. I see
Yeah,
Cindy.
same for Mobile. Almost all of the participants came back out from that revocation on AOT.
Perfect. So as we were just talking about the Kendra's law started at AOT in New York, and Mobile obviously built different criteria into their program. Maybe we can talk, Richard, a little bit about starting programs, building programs, what goes into those conversations.
Yeah, thanks. And I thought it was great to have Cindy here. She's done it twice, both in Baldwin and Mobile, and it was a process, right? It's not something that you just hit the ground running with. There were a lot of things that you did and that you think and you maintain are important kind of to this day, not just for starting a program, but for moving up programs that are already going. So this was kind of one of our first signposts. We wanted to kind of talk about what does it look like to build an AOT program right? Because to our thinking, if you build it right, it's easier to sustain it. And that was one of the points that Marvin brought up earlier, is kind of thinking from the very beginning about how do we sustain this program, because our SAMHSA program funding dollars are going to run out soon, or we need to go back up through the legislative cycle for more funding. So we wanted to talk a little bit about building it. But here I wanted to kind of hand things off to Cindy a little bit and talk about what you thought was important, Cindy, in building this in an environment that varied judicially and all that went along with it.
Okay. So Richard asked me this question, and I mean, I could talk for days on this question. So I tried to think of what were the key things that were super important. And one of the things that I say over and over, if you've ever heard me speak about AOT, is SIM mapping, system mapping, to get all of your partners in the same room, to know who your partners are, to know what it is that they expect, where they see gaps, because they may see gaps that you don't see, and vice versa. And having someone outside of your community come in and do this makes a huge difference, because they're able to say, well, I mean, Sergeant McCarty, you've got the data. Why don't you just share it with Doc? And things like that happened. And so, we've done 2 SIM mappings. We've done an initial and a remapping. And I think our system works well together, and we have those relationships because of that SIM. And that SIM has led to sustainability. It's led us to branch out into other programs where there were gaps, like our clinical co-response. We have 24/7 telehealth through iPads in patrol officers' cars. I mean, all of these things that we do together from that initial mapping to be able to provide access to anybody, anywhere, and to be able to support our stakeholders, our officers, our court, all of those folks, NAMI. So I think, that's an important component of it. And then one of the other things that I always say is, go ahead, Meryl.
I'm going to go back. Go ahead. No, you guys. You always say, did you want to go to the next slide? Is that?
Yeah.
Okay. Because we're going to go back and forth, if you don't mind, Richard, on some of these slides. So Cindy, go ahead, finish your pitch, and I'm going to take you back to the slide, if you don't mind.
Okay. So one of the things that I always say is AOT is not ACT. I've had an ACT program for years. ACT is a Medicaid-based voluntary program. The staff that work on ACT know their population. ACT has people who want to be on ACT, who who need that level of support, and ACT very much becomes a family for those participants. It has its own fidelity scale, its own specified intensity, but AOT is different. And you can have some AOT people on ACT, but AOT should not be an ACT team only. AOT needs to be a team that has some experience dealing with folks who are under a court order, who may not want to be there, and who can be creative with their encounters with the AOT participants. And it's not going to be an hour therapy session. And I think that probably goes into the next slide, but it's not, I know we have a lot of folks who just come out of graduate school with their master's degree in social worker counseling, and they think that they're going to be sitting in a dimly lit office having a therapy session for an hour with some candles and music playing, and that's nothing like AOT therapy. It's sometimes 15 minutes at best, and it may be that you're using a deck of cards to get the conversation rolling, and it may be at somebody's house. So it's very different, and I think being intentional about your AOT team and what that team looks like, and that it's sort of a specialized team, is really important. And then the next slide there is hiring and retaining the right people, because those staff burnout is easy for an AOT team, and having staff who can celebrate those small victories and realize that slow progress is big progress in AOT, and not limiting what people can do, but taking their goals and working towards them. Like if I have somebody coming out of the hospital who says, I'd like to work full time. Okay, let's figure out how to get there. We're going to do it in small steps, but let's figure out how to get you there. Not saying, oh, this person has schizophrenia and they'll never work again. It's being able to meet the person where they are, find out what they need. And I think one of the things that happens, especially in community mental health and this kind of work, is that we get a lot of people right out of college, and we can all see your schedule there. It's covering.
That wasn't me. I don't know who that was.
Okay. So we get folks who may stay in a community mental health center just for a year or two and get their license and move on to private practice. And that turnover hurts your program, because the participants in AOT have had a lot of trauma. They've been through a lot of clinicians. They've been through the system a lot. And so those kind of continuous cycles really hurt the program. So it's important to get people who want to work with a population that can sometimes be really tough to see rewards and motivation in. And so I'll open it up from there.
I'm gonna take the moderator's prerogative and move backwards here for a second. I'm gonna move
All
back
right.
into slides and to get perspectives on both from others as well. So partners is in the first line here, right? And planning, cross systems programs like AOT, like mental health courts, et cetera. Partner is, stakeholder partners. So who are the partners that are important to be at the table in planning a program? Who were at the table maybe when you did it, and who maybe would you say, well, I should have had that other, if I'd known better now, I would, do it again with, so who would that be?
So for us, that was all of the treatment providers, the hospital, emergency room providers, law enforcement, the courts, both civil and circuit, the jail. There's a mental health provider in the jail. There's also the warden at the jail. NAMI was a critical component for us. People with lived experience, and other like smaller agencies. There were some faith-based organizations, substance use providers, things like that were critical in not only like taking on parts of the program, like we partnered with a food bank in Baldwin County, and we were able to get food boxes for people who didn't have any income, and like all of those things that you never think about. And the great thing about sim mapping is you figure out who those people are, but then they know somebody who knows somebody else who knows somebody else. And a lot of times those decision makers also know people who hold the purse strings. And so when it comes to sustainability, having those people at the table from the beginning, and they get to see your data in quarterly calls and get to see what you're doing and get to see how people are doing in the program, that's where you get funding to
Interesting.
continue it.
That's great. Thank you. Marv, do you have a sense about, do you recall, I mean, I was around, but I wasn't in this position, anything about the planning process in New York State back in 2000? I don't know if you were involved at that point or you looked at any look back from when you did come into New York.
You mean the planning of the treatment plan or development of the program?
Development of the program.
Yeah, so you mentioned before, which was the big difference between upstate and downstate. And we do have a map that shows the density of the AOT orders, and it's remarkable that downstate is just covered with dots of AOT orders, and upstate, except for particular places, is much less populated with AOT orders. So why is that? Or why was that? And my sense of it, and maybe it's wrong, is that in New York City, the hospital system, the city's hospital system, really carried water for AOT, and that they really implemented it. You know, the statewide, the OMH was really critical in developing the data systems. The data systems in New York are awesome. I mean, anybody can go to the OMH website and see incredible detail about the AOT system, you know, statistics and all. But it seemed like the development of the system itself was really carried by the hospital corporation in the New York City region. And although the state certainly contributed the idea of the AOT teams and their oversight. So there were a lot of different critical elements that came together. And I wish I had seen more of that on the ground. You know, I did see the pilot at Bellevue before it was passed statewide, and the pilot was odd in that there was no removal orders. So there was no, quote, enforcement. So it was, I think the additional element of the removal order in the statewide system was also another important thing. But, you know, one of the key issues I think is, well, what is the glue that holds AOTs together in a particular region? And something went on in the hospital corporation that really owned AOT, where I'm not sure you saw as commonly other places.
Yeah, I think actually, as you talk about it, two things come to mind. Just one is that, you know, because Cindy is actually talking about, you know, a mobile county, right? One county. So one of the ways that New York State implemented it and does a lot of implementation for other programs, given its the differences and its vastness, is to turnkey stuff to the counties. So they created a centralized law, and as Marvin is saying, we'll come back to the data, some centralized data and some oversight, but implementation was turned to the counties. The teams were county teams. So it was that created both variability, but then obviously some ability to look at local services and kind of, because so each county is somewhat distinct. The other thing I was wondering, maybe Nat has something to kind of offer here as well. One of the things that I know came up early on in planning, and I'm wondering if this is something, Cindy, that you or maybe others had found in mobile, was that two of the stakeholders that were important in New York State were the families who were very much in favor of AOT, right? Who were very much wanted some support for their family members who weren't doing well in the community, and some external support for structuring a response, and the peers who were very much against it, and felt it as a loss of liberty. So there was a bit of a conflict, between NAMI and the peer organization. It was a split, where they're often both advocating together for services. Here, there was a big split. And I'm wondering, is that something that you experienced, or?
Well, I think, Merrill, one of the geniuses of Kendra's law
Yeah.
was that it, had an allocation for the program, but it also infused more than 200 million new service dollars.
Yeah.
And it was really hard for the opponents to push back very much, since it's a carrot and a stick approach. And I think that that's really what, provide a lot of momentum for the law.
No, thank you for that. Nat, I know, do you know anybody who was at the table for the planning process? Cindy had mentioned peers. I don't know if you were already in this system at that time.
That was directed at me, Mr. Rotter?
Yes. Yes. Sorry.
No, I do not remember it. I do not recollect that. I'm sorry.
No worries. And Sergeant, were your colleagues at the table in the planning process, or people? Do you know what the law enforcement response and the planning of it was in terms of their roles?
Yeah, we were at the table, and we were just trying to make sure that we could, so to speak, just make sure that we get our officers in position to where we could be doing a better job with addressing the population, period.
So, and you're referring in that context, like for training, CIT training, that kind of thing?
Yes, sir, absolutely.
Can you talk a little bit about that for a second, about how the CIT is part of the AOT response here?
Yeah, what it did was it allowed us to do some training for our officers, in the sense of we got 40-hour CIT training, and that training is helping our officers do a lot better with addressing the population as we respond to them in the field. The AOT system allowed us to get data sharing, and that allowed us to get to the iPads, which is available 24/7. And what it does is put a clinician in the field 24/7, so to speak. So with that iPad, and make sure the officer gets the proper information on who we're dealing with, and then just simply connecting them with that clinician on the iPad right then and there. It just gives us clinician in the field right then. And then that way we can divert them from the justice system.
Oh, great. Thank you for that.
Yes, sir.
So as you see, I've kind of moved backwards in the slide here because I wanted to end at least this part of conversation with a couple of issues that I didn't want to run over too quickly here in the planning process. One of the words that jumps out at me from this slide, Richard, right, in the plan is fairness. Right, and which gets to both issues of capacity, gets to issues of race, gets to issues of criteria. So I'm going to maybe ask almost everybody here, right? But we're going to start with Cindy, if you don't mind, put you back on the hot seat. How did you address fairness? How did you try to maximize? Again, you can't guarantee, but in your planning process. Then we're trying to ask Martin about what he found in New York State and others. But Cindy, when you go first, if you don't mind.
Well, I think in terms of like underserved populations, the underserved population in Mobile it accounts for a large percentage of the population on AOT. And so our demographics of AOT represent the demographics of the city pretty much spot on. And it's not something we intentionally set out to do. It's just something that naturally happened, but that we did keep an eye on to be mindful, and I think having that relationship with law enforcement gives us access to people who might not ordinarily come into contact with the mental health system. And, Sergeant McCarty might say, hey, I'm gone out on this person in the bottoms 5 times. And he says he's never been to Alta Point, but he needs something. and we go out and see, and yeah, this is somebody who is a good candidate for AOT, who's never been in treatment, who has a serious mental illness, and it isn't getting the treatment that they need. And so, police go places that clinicians sometimes don't always go. Our crisis team goes to a lot of places, but police go to places we don't. And so, and just being mindful of different cultures and different paths to the program, and making sure that we were representing everybody well, and that the team is diverse too. It's not just a bunch of white faces serving half of a population of brown people. It's everyone representative of who we're serving, or trying to be, and then keeping it to where we didn't use coercion. We didn't say, well, we can revoke your court order at any time and send you back to the hospital if you're misbehaving. So it's about language, and the language the team uses is it impacts the fairness as well.
Thank you for that. I'm going to turn to Nat and then come back to Marvin. Just Nat, your experience of the AOT. How did you experience fairness, and what was, and I guess part two of that is, what was important, if assuming that you felt felt fair or unfair parts, what was important, what moved the needle in that direction? What made it fair or what made it unfair in your experience?
I think the most astounding thing, most impactful thing was Dr. Gibson had mentioned meeting people where they are. And I think that was very fair, of the treatment that I received from my therapist, my case manager, and my speech specialist. Like fortunately, had to only come out to my house for a couple of times, but the case manager and the peer specialist, they came weekly, and we were able to converse and just relate and just talk on various topics and stuff like that. So I never felt like anything was unfair or biased or anything like that. I thought they did a wonderful job.
Thank you. Marv, I know you did one of the things you looked at when you came to New York. So what did you look at and what did you find?
So I think it's a very important issue, because if you don't attend to the various issues relating to fairness, you're going to get a lot of community opposition, a lot of opposition from different stakeholders. So one aspect is procedural justice. Do people think they got a fair hearing in the court process? And so I think that requires, attention. I think by and large in New York, that was not such a large issue. If anything, there was more procedural impediments than anything else. But the two issues we looked at that were substantial and are substantial other places is race and queue jumping. In race, there was a claim by the New York Lawyers for the Public Interest that Kendra's law was racist because there were disproportionate numbers of African Americans under Kendra's law. We looked into it, and it was correct on a sort of raw population basis. But when you dig into it, what we found is that, African Americans vastly outnumber other ethnic groups in the public mental health system, and had vastly higher rates of involuntary commitment, such that they were eligible for Kendra's law. So Kendra's law wasn't selecting people for who are Black. It was the eligibility itself. So that doesn't mean that life is fair. It doesn't mean that the public mental health system isn't racially biased in how it functions, but it wasn't Kendra's law itself that was causing the disproportionate number of African Americans. And so we argued that that was a fact of racial disparities in the way the public mental health system works. The second issue of queue jumping is more problematic, and that is the claim by advocates, or the argument that advocates, is that if people in involuntary treatment get preference for services, you're sort of transforming the public mental health system into an involuntary system, and you're denying people who want treatment to get treatment. And it's a very tricky issue. It turns out in New York, when we studied that issue, that the infusion of the new service dollars negated the effect of queue jumping, because there was so much new service dollars in the 200 million for the new act and other services, such that everyone could have good access to services. However, we caution that, as you know, over time, unless that pie was made bigger, there could be an issue of queue jumping. So that is an issue, and an issue that people have to face, is that you don't want to create a system in which people under involuntary care get much higher priority for services. And it's a thorny issue.
I agreed, and I'm going to come. I think moving to it's a nice segue to the measuring programs piece. As we get into that, we'll look at a little bit at the dosage, legal and clinical dosage. And one of the challenges, or at least one of the responses to the issue about queue jumping is that what's happening. Another is your frame, right? Another way of framing the question, or framing the issue is it's providing higher level resources or to the highest need individuals or the higher risk individuals, right? Which is probably clinically and perhaps legally, but certainly clinically appropriate. So to the extent that AOT is identifying individuals or selecting for individuals who are higher need, that they go to the front of the line, is prioritizing services for the highest need folks, in a sense. So again, a good answer is expanding the pie, but when there are resources making choices, often you're choosing higher need people. It's just sharing one of the responses to that. Marv,
I think that's an excellent point, and I should have said that, because it's part of how you see AOT. Like on the race issue, if you think AOT is a good thing in that it prioritizes care for people most in need, then it's a good thing to get an AOT program. But if you think it adds a measure of coercion that's unnecessary, you think it differently. So the fundamental thing is how you think about AOT as a sort of a proposition. And one other thing I'd add to that is there's a much different ethical framework in which you look at a step-down program versus a step-up program. Step-down means that someone's under involuntary commitment and they go to AOT as a less restrictive alternative. That's far different than a de novo commitment in the community. I'm not saying one's right and one isn't, but they're much different. And most of the opposition to AOT comes from the people who de novo get put on a community order.
Yep, thank you. I was going to move to the next section. Before we do that, two things. One is, I want to note, just to echo part of what Cindy said in this slide, which is that AOT is not ACT, and they are different. And just to differentiate New York quickly from the mobile experience, outreach services are legally required as part of any treatment plan in AOT in New York State. That can be ACT or FACT or an ICM worker, so there has to be baked in there. But again, from a team perspective, right, the ACT team, full-on, regular, reimbursable ACT, is a treatment in the community. The AOT team in New York State is more of what an old PRA guy, Hank Stedman, used to call boundary spanners. Hank Stedman, for some of the old folks who remember Hank. So Hank used to call boundary spanners, people who basically are not providing services, but are spanning the court and the community in a sense. And so the AOT teams are indeed separate from ACT, but clients are often getting full-on ACT services. And the ACT teams have to know a lot about how to work with people under a mandate, which we can talk about further. But before we move to the next section, we had a very good question, I think it gets to program planning, Richard, that I'd like to call out. And the question is about working with individuals under AOT who have cognitive impairments, TBI, autism, perhaps, and basically how you think about AOT in that context. Are those people eligible for AOT? Do you work with them differently? What are the challenges for AOT for these clients? Any thoughts for anybody have about that?
Cindy, Marvin, I think
Cindy,
in your experiences, and then Marvin too, generally about the challenges of treating the kind of added on complication of intellectual developmental disability.
Well, one thing I would say about that is AOT is agnostic about why someone's not adherent. So, and by that, I mean, it can be that the person's sort of fundamentally opposed to taking treatment, sort of as an ideologic position, or they just don't want to take their medication. So that's one category. But there's a fair number of people who just can't adhere. And because they have cognitive problems, or they, you know, as you suggest, they have traumatic brain injuries or what other. But I think the AOT program can still function for them if you make sure that the clinical services they need are still in place. So the model doesn't fall down just because the person can't adhere or they have such large cognitive barriers to adhering. It just has to adapt clinically, in my view.
Cindy, do you track individuals differently, or are these eligible conditions for AOT in your program?
As long as there's the presence of an SMI and there is, I mean, depends on the level of cognition. Now, major neurocognitive disorder is definitely excluded. And usually it's the primary issue. And so it makes it much more complicated, and especially if you've got other issues which have often referred to as the Fab Five at the same time, which is a serious mental illness, substance use disorder, intellectual disability or cognitive impairment, you're unhoused, and personality disorder. If you have 4 of those things, it is almost impossible. If you have 5 of them, it's really contraindicated. So I think you have to adapt. You don't always get to choose, or you really never get to choose who your participants are, in a sense. You can argue with the hospital about who they're going to put out on AOT, but once they get up and testify on the stand that AOT is their decision, you're getting who you're getting. And so you got to make do as best you can. And you know, I think you know, AOT is definitely in the realm of competency restoration now, and so there's space for that, but it has to be adaptable.
Great. Thank you, Cindy. So looking at the time here, to move into the next section. We've been talking to date, you know, heretofore about program characteristics, program development, important elements. I'm going to move now into measuring efficacy as part of you know, an AOT program. And Richard, you want to kick us off in this section?
Yeah, thanks. And I think here's a really big difference. You know, in the New York AOT evaluation, Marvin and his research team were limited to kind of secondary administrative data across the state, and we did a more in-depth analysis of 6 counties and arrests and things like that. But we were a little bit more limited in what the nuance of data that we had. And I think one of the amazing things that Cindy has done across both Baldwin and Mobile counties, and Cindy and I have been working together for a long time on this, is just kind of measuring the right things, measuring the things that matter, and counting everyone, because everyone goes through the program, and they went through the program for a reason, and what was their experience. And so I think programs have a really amazing opportunity to measure more nuanced and help the programs refine things, because there's a slide here, a right corner bottom slide from Cindy's Mobile program that shows arrest rates before someone was in AOT. That's the pre-period, the during period. Oh, it just went away. Hang on, sorry. I want to stay here. This one.
Yeah.
Arrest rates during AOT and hospitalization rates, right? These are arrest and hospitalization rates. And maybe how they kind of rebound or don't when the AOT order is removed. And sometimes people stay in treatment or don't. But these are also stratified by risk, and that's something that, and need. And that's something that Cindy did an amazing job in her program with, is tailoring treatment specifically to the individual based on risk and need. And I think that goes back to the fairness thing too. That's right, the fair way to do it.
Fair, I would just say efficacious, right? The literature from court-based treatment or court-mandated treatment in the criminal justice system, which I think we have some things to learn from to make AOT more efficacious, is basically using risk to try to figure out dosages, and level of supervision, level of treatment, and stratifying outcome, because low-risk people are not going to get in trouble regardless of the AOT or not, right? So.
That's exactly right. Couldn't have said it better. So the measuring part, and I want to. I don't need to spend a lot of time here, except count the right things and count everyone, and don't burden AOT participants with primary data collection. It is not necessary if you have good system partnerships and can get treatment, services, all of that data. You don't need to spend time burdening clients with primary data collection. I think, Cindy, right? I mean, that's kind of where you and I have landed on this.
Absolutely. I mean, everything's there in service records and arrests, and all of that data is you really, the long interviews that sort of come as part and parcel with the SAMHSA grant are not necessary to determine if your program's effective or not.
Yeah. And I think, and I want to spend a little time talking about what we're talking about measuring, right? Arrests, hospitalizations, all of those kinds of things. But I think what we're trying to emphasize today is that there is a legal dose and a clinical dose. And I think we, services researchers and clinicians, for a long time ago, we're much better at targeting clinical dose to need. We have not yet mastered in a legal clinical intervention how to target legal dose to need as effectively, I don't think. And so I think it's important to measure and remember kind of the legal processes and how they may be affecting AOT and how they may be affecting the clinical program. Right. I mean, the example earlier was made, and Marvin talked about the glue of AOT, and Nat talked about kind of the ultimatum, and hearing Cindy's team like, we can't go away. We're working with you, right? The judge told us to. So here we are. That's all shaped by the legal dose. So what does your judge do? Does your judge sign an order and then we're done? Document that. Right. I mean, that's part of the legal dose. And so I think go ahead.
Because I think Nat talked about ultimatum in our panelists when we talked about it earlier, and maybe not for the larger audience. So Nat, maybe we talk a little about that legal dose issue, and talk about define what you meant by ultimatum for the larger group that's now joined us.
Right. Yeah. The ultimatum was basically like, I just did not want to be in involuntary commitment for so long, because I still have, like, I still understand and realize that, like, I can get the right medication and the right, and with, along with treatment, and so that I can be back out in society. And that was like that. The ultimatum was because, like I had mentioned, I had seen the severity of some other peers that were with me, and it's just it scared me basically.
So, I have a comment and a couple of questions for just the sergeant from Marvin on mine, Richard. So the comment is just as an important take-home point here, wherever you land on dosage, the how you measure these dosages is the differentiation that you're making here, Richard, between legal and clinical, right? Because again, as I said when we first at the top of this session, part of the conversation ought to be what is AOT adding, right? If you have a wonderful ACT team who's doing the perfect clinical dose and everything is going, is AOT adding something? Not just suggested. Well, that ultimatum is actually a important addition, right? It's the legal dose that it's adding efficacy and stability and assisted in that context as he described it, right, from his experience, which is not necessarily be clear every peer's experience, but certainly is his experience, right? And want to honor that. But just that differentiation between those two things as we think about why AOT in general or why AOT for this client, I think that differentiation I think is important. And then I had a question, maybe this is a little provocative but you can Sarge if you don't feel like answering, but one of the complaints that we get and we've heard nationally and certainly here in New York City sometimes, right, is cops not wanting to be social workers, right? I shouldn't be in this bit, so mixing this legal and clinical stuff all together just makes me be something that I wasn't supposed to be, right? So how do you think about that role or you're muted, Sergeant.
Can you hear me now?
Yep.
Good. All right. So I think one of the biggest things is we wear many hats in law enforcement, and we just have to we try to preach that in academy. You will wear many hats, and the biggest thing is yes, we're going to be the first ones to call. They get that call because people see things that they do not understand, and the first thing they do is pick up the phone, call 911, and we're the first ones that they send. That's just the nuts and bolts of it. But on the back end of that, I think AOT, what it's done is build a relationship. Okay. Again, we are usually the first ones that go to a mental health crisis because everyone thinks that something weird is going on. They don't quite understand, so they think it's a criminal aspect to it. Not all the time. It's made a huge impact on the amount of time that we spend on these calls. So we don't have to necessarily be social workers. What we're doing is connecting. We're being the connectors of what's necessary. We've been doing this with them since 2019. And before we started working together, I mean, the support that they provided for us with AOT is unmeasurable. So that's the biggest thing.
Right, thank you. And Marv, were you able to, in your study, look at the legal dose versus clinical, in some way, shape, or form, differentiate those two things, or unpack that at all in the work that you did in New York?
So the proxy for that, or the way we measured it, had to do with removal orders in terms of how often the court had to get involved before the initial treatment plan. And by and large, New York is not what you'd call an active court model. So there's not a ton of involvement of the court. It's really the mechanism of action, and what we understand is the program itself once the court order is issued. There are places in which the AOT operates much more like a mental health court. But what we'd say what I think we'd say about it is it's not essential, that there are successful programs that does not require that sort of active court model.
Great, thanks.
Real quickly, I want to jump in here because this to me highlights measuring the right things, right? And being able to show kind of before, during, and after what's happening. And this was, Cindy has great relationship with not only Sergeant McCarty, but Mobile police generally. And Cindy tells a great story about police officer who kind of lives in an office down the hall and never comes out and is the data person, right? And getting to know that person and how that led to data sharing. So very relational as well. But then what you do with the data and the stories you can tell with it, and I think this is something that Sergeant McCarty and Cindy can speak to, is when the AOT order is active, when the treatment team is engaged, and like use of force for police on calls falls. I mean, it's reduced to approximately 0 during the orders. And any remaining use of force during an order is very small numbers. There are some rebounds, but the rebounds, Sergeant McCarty, I'm really interested in your take on this. They're for people who are using certain substances. It's meth and spice and a hard substance use kind of combination to manage on an outpatient basis. And so Cindy and I don't know, Nate, can you guys just talk for a second about what this data has meant and how you've used it? And what you guys see on AOT and off for something like this?
Yeah, I think it was important to measure because use of force incidents are something that the city and the police department are always going to be concerned about. And the use of force is on a continuum, anything from having to go hands-on to get someone to comply, to taser, to then lethal. And, I think there was a period of time where there were more officer involved shootings and they tended to be people with mental illness. And that's a nationwide thing. That's not a Mobile thing. And I think it came from a lack of understanding. And so the relationship that we built and the training really made a difference in that. Plus the element of us always being present with the AOT population, bringing those numbers down. And Nate, can you speak to what use of force means to the department? And you're on mute.
Yeah, so just going back to what Richard said earlier, what does meth and what does mojo use look like? Like mental illness. And that's something that training has hit on very much for our officers. We're starting to understand and know the difference, and also kind of understand why individuals who are living with mental illness turn to meth or mojo, and try to make sure we can, instead of making this a criminal situation, let's try to see if we can funnel them to the right resources, correct? The use of force. The use of force has been a huge difference for us. Whereas again, when we get called out to these things, again, we have individuals in the community who do not understand what they're seeing. And so we already have a heightened sense of vigilance going in, but now we come in with more patience, we come in with more empathy due to the training that's been provided. And we're able to once again recognize, okay, hey, this is not what it seems to be. So let me be a little bit more patient. Let me approach with a little bit more empathy and see if we can get a little bit rapport, and the officers know how to go in and have a conversation with someone who's in a crisis, and they're patient. And that's the biggest thing. You got to be patient.
And going to zoom out here for Richard for a second. Just one of the important things I think in the several slides you've had about this evaluation, right, is the pre, during, and post periods of measurement to looking at AOT efficacy, right? Looking, et cetera. I want to just call that out and maybe ask Marvin, who's both looked in New York and elsewhere, about that kind of approach. Because it seems to me that's really gives you a robust sense of what's happening during and what may be enduring from AOT involvement. So any thoughts about that whether I don't think we did that in New York exactly, maybe you did, but and how you think about that kind of approach to data?
Uh, you know, that is, I mean, I think Cindy's group and Richard have a great advantage there because they get those data. Those data were harder to get in New York. We also didn't have a lot about housing stock and housing, which is another critical aspect of the program. So we just didn't get great insights into that, I'm sorry to say.
But I think I just want to suggest that people think about program development and thinking about how you get sort of build those data in early is, I think, would be very helpful. And agreements to get it after those kind of, because it's such robust findings that really shows us where AOT played a role.
Yeah,
And that's crucial to sustainability.
Yes.
You know, like that use of force, like you know, for a city, their bond rating is based on the number of lawsuits they have and things like that. So the use of force and the officer related shootings going down helps the city. And then it creates a funding opportunity because where their bond was sky high, now they've got some leeway and extra funds. And so if you can attribute that to your program or part of it to your program, then that helps when you're asking for money.
So
And
maybe just with that, sorry, go ahead, Mark.
Yeah, one other thing about it. I think in terms of data collection, so partly my answer to you about the data we got is New York was very good at saying no to data collection. And despite the fact that the legislature told us to do the study, multiple parties told us to take a walk when we asked for data, even if, and sent us down alleys of, IRBs that were never going to be breached in our timeline. So I think you have to also be realistic about what you can get and making the best use of it, because you don't want to spend the rest of your life trying to get data that you're never going to get, which is a point Richard was making about some of the consumer data. You need to take a pragmatic approach.
Thank you for that.
And Merrill, real quickly,
yeah.
Merrill, it's much easier. You mentioned this. It's much easier to build it early and small.
Exactly. Yes.
And show that you can get the data, right? And the one thing that Cindy and I are still working on in Mobile and Baldwin is EMS data. We haven't looked at that yet. And that is such a large cost driver, right? Sergeant McCarty talks about a call, often an ambulance goes there. There's some, so those EMS calls is something that needs to be built in as well. Merrill, to your point about pre, during, and post, I learned that from Marvin and Jeff, and it's, I think, the best way to do this given the legal clinical aspect of this. See what happens when you remove the intervention. That's why the data are so important. You need a robust pre-period and a robust post-period. You can do all of that without burdening Nat and his experience with AOT and asking him during the program kind of stuff, right? The procedural justice stuff, ask away. How is this going for you? Are you being treated fairly, right? The other stuff, that's not relevant to the evaluation is kind of my approach.
So as we kind of circle, kind of round the final lap here, the final curve, bringing us home in the next few minutes. So we have we're going to talk a little bit about using all the stuff we talked about towards sustaining programs. And can Cindy use the word sustaining just a moment ago and kind of want to lean into that a bit. So why don't you, Richard, take us into this topic, if you don't mind, and then we can get some comments about this. I don't know if we'll have time for all the slides. We don't want to, because we have to cut some concluding remarks.
No,
so
absolutely. We won't have time for all the slides.
Yeah. So
yeah,
help us figure out what's important here that you want to share among the slides.
Yeah, so a couple of things. Cindy and I, as me, as for the evaluator of her program, Baldwin and Mobile, spend a lot of time talking. We spend a lot of time going over data, and I will send Cindy 5 IDs and say, I need you to pull up who these people are and have them on your screen. I have some questions about what's going on, right? We're always trying to figure out what's going on with the program and how it can be improved. Substance use, to me, I think represents the clearest example of this, because Cindy and I noticed in the data that people with methamphetamine, people with synthetic marijuana, people with cocaine and opioid use, they were staying in the program a lot longer. It was a lot more difficult to discharge them. And when they were being discharged, they were having much bigger rebounds, right, to their pre-AOT state. And so we started talking about, what can we do with this? What is happening with this group? What are the implications for your treatment team? Because your caseload now is essentially a very high risk, high need population who is very meth dependent. And so we use data to talk about that and field and surface those issues. And I think it helps Cindy and I think about next steps. So we've started talking about contingency management programs and way those might be funded. So I don't. It's a lot of what we're talking about here. We've talked about earlier. It's just ways you can use what you've done to keep things going. But there it is, Meryl. I want to get to the costs real quickly and have Cindy talk about how she has used these cost data. Cindy, go ahead.
Yeah, everything is quantifiable in terms of cost, and cost is what hits your decision makers with the sustainability question. If you can come to them and show where you've saved money. And so we went to our local emergency departments and asked, what is the average cost of treating someone in an emergency department with in a psychiatric crisis? What is the average cost and average length of stay for somebody with a mental health issue to be arrested, jailed, and treated in jail? And so we can break down all of those things and show that the program saves money, and it saves more money than it cost. We know what the per participant cost was at the end of it, because we had a fixed amount of grant funds, and the cost is significantly less to do the program than what it saves the community. And then some of those things like lawsuits and things are not even measurable cost wise, the prevention of that. So that's where the conversations really happen around sustainability, is being able to demonstrate this.
Yeah. And I want to call out something you have on the slide here, which is so important, and which is why you almost have to get to the highest levels of the local of government here, because it's the wrong pockets problem, right? We do this in the criminal justice side. You save jail days, but that doesn't save money for the mental health system, because who are paying for more treatment. I mean, how do you move with them? And the money doesn't move there essentially. And but at the governor's level, there's a bigger budget there where there's some movement. So I think you're calling that out. I think you do here is really important, because I think you have to own that argument if you're going to answer it in some way, right?
Yeah. And that's, having those people at your SIM meeting who are decision makers, but who know the bigger decision makers and can say, I'm going to lobby for this. I'm going to lobby that, 5% of the budget for jails is moved to mental health or whatever.
That'd be super. So maybe just I guess I'm looking at the time here. We have time for a sum up, so I'm going to try some final notes here. That's okay, Richard. So maybe you want to talk us through this, or I can do it, Richard, if you'd like. We're sort of summarizing what we talked about here, right? That you want to build a system, and Cindy, as you just did again, has used the term about mapping, using SIM mapping or mapping your age, knowing what's out there essentially, but really building a program and thinking in a very both proactive and intentional way about the different aspects. Who's in the system? What do you mean by AOT? What do you mean by services? How do you, et cetera, is it important? And having the right people at the table, including people with lived experience, because it really is a cross systems thing, I think is something you've heard multiple times from everybody this afternoon. Secondly, measuring what you do so you can have a sense about what you're doing, so you can, for improvement purposes and for the client experience purposes, and building that measurement in from day one. I think, though, in some ways, I think what you heard from Marvin in part is that the legislature built in the idea of having an evaluation into the legislation from day one. but they didn't build but the evaluation itself wasn't part of the, the original program. It was back ended. And so then there were both advantages in terms of New York State's data set, but also limitations because it wasn't baked into the program. It was an expectation of the program, but the actual system for the evaluation wasn't baked in, as it sounds like it was largely in Mobile, Alabama. Big difference, I think we heard there, which is important to note. And then, as Cindy suggested and Richard suggested here, I think sustainability is often built on data, right? So data helps us do a better program and do better by our clients, but it also helps sustainability because it's that data, both clinical data, legal data, cost data, that is actually going to allow our funders to support the program. We have seconds here. Any last words from any panelists?
Data and those stories from Nat about what worked and that qualitative, that mixed methods approach, I think is also important. So not just the quantitative, but Meryl, you mentioned it, the stories as well.
Sure.
And, I think that's important. So thank you, Alon. I'll hand it back off to you to kind of wrap things up after panelists have a final.
The last thing I would say is, the perfect is the enemy of the good in terms of data. And if you hold out for the purest data, you're not going to have anything. And it's particularly, in terms of monetizing or trying to do cost things. There are people who are going to be incredible purists about it. And you just don't want to do that. You want to be pragmatic about the data you collect.
Thanks, Maura. Ilan, back to you.
Yes, thank you again, everyone, for a wonderful panel and discussion, especially Mr. Pham and Sergeant McCarty. Thank you for your time. Doctors Gibson, Rotter, Schwartz, and Van Dorn, thank you all. And thank you all for participating and coming out to our third and final webinar in the Assisted Outpatient Treatment AOT webinar series. You can find our full series on our YouTube channel, and we will put the link in the chat. PRA helps communities answer the right questions before establishing or expanding AOT programs. We co-design implementation and evaluation strategies grounded in evidence, existing capacity, and your local priorities to address your community's needs. If you're considering starting or expanding a program, PRA can help support design, implementation, planning, and evaluation. And feel free to join our listserv. You can visit our website at prainc.com to stay engaged with us. Thank you all again and have a wonderful afternoon.